For our next session, it's titled Leveraging Momentum in Mental Health Promotion. And we're having a moderated panel presentation where we'll explore mechanisms for affecting change in Canadian mental health promotion, including people, partnerships, policy, place, and practice. It is with pleasure that I introduce our panel moderator, Dr. Katie Dowling, who is our first postdoctoral fellow with the KDE Hub. Katie spent the last 10 years living in Ireland, working in the field of mental health promotion, and we're grateful that she's with the Hub and her passion for mental health promotion is evident throughout her work. Over to you, Katie, to introduce the session format and our panel members.
Thanks a million, Alice. So thank you everyone for joining, and I want to welcome you all to the session 1C, which will be a panel discussion that's really focused on this main theme of the conference, which is leveraging momentum for mental health promotion. And specifically, we're going to be looking at those key mechanisms for affecting change. I'm absolutely delighted to say that we have a great lineup of speakers for this session who not only offer a diverse range of perspectives in terms of topic areas, but will also speak about momentum across different fields of practice, policy, and research, really in order to strengthen the mental health and well-being of Canadians. So we have three panelists in today's session: Margaret Eaton, who's the National Chief Executive Officer from the Canadian Mental Health Association; Shelley Cardinal, who is the Senior Director of the Office of Indigenous Relations with the Canadian Red Cross; and finally, Dr. Ketan Shankardas, who is an Associate Professor at Wilfrid Laurier University. I will introduce these speakers a little bit more before their presentations, but if you do want to seek further details on their bios, you can link into Whova to access this. So just to give you a brief overview of how the session will run, we were going to start by hearing from each of our three panelists, and they will each deliver a 10-minute presentation around building momentum for mental health promotion in their respective areas. Following this, we will have 15 minutes to open up the floor to a panel discussion, and we would encourage questions from the audience. So if you do want to submit a question, you can do so within the Zoom chat, or if you prefer, you can use the Whova platform. And we would encourage you to submit questions during the presentations, and we will try to get to as many as possible during the audience session period. So as you can tell from the initial introduction of speakers, we are really in for an exciting and fruitful session. With that, and being conscious of time, I would like to turn it over to our first speaker, Margaret Eaton. So Margaret is the National Chief Executive Officer of Canadian Mental Health Association. She has over 20 years of leadership experience in the non-profit sector and has a commitment to working with key stakeholders across Canada to reimagine the mental health system. I spoke with Margaret last week, and I'm just so excited for her to share with you some of the important work that Canadian Mental Health Association is doing for promoting the mental health of populations. So with that, I will turn it over to Margaret.
Thank you so much, Katie, and thank you very much for inviting me here today to talk about momentum, because I feel like there really is extraordinary momentum in mental health right now, and I really hope that that gets translated to mental health promotion. So I want to tell you a little bit about some systems change work that we're doing at CMHA. And I want to start out by telling you a bit about our work. We were founded in 1918, back in the last pandemic, as the boys, and they were mostly boys, were coming back from the First World War. And our mandate has really grown over that time, but we are really the largest community-based practitioner of mental health across the country. We have our national office where I'm speaking to you from, and we have 11 provincial and territorial divisions, 7,000 staff, 11,000 volunteers across the country. And we offer a range of programs, but mental health promotion is really fundamental to the work that we do. We're involved in mental wellness programs in schools and on campuses. We do workplace mental health programs. We do a lot of work to reduce stigma and increase awareness of supports through things like our Mental Health Week, which is coming up in May. And we're very involved in the social determinants of mental health. Many of the CMHAs actually run housing programs for people with mental illness and are engaged in employment programs. So really, mental health promotion and prevention is at the heart of what we do. And on our third slide, I wanted to talk about the fact that what we've seen most recently through COVID is that millions of Canadians are struggling and don't really know where to turn. And unfortunately, that has meant huge waiting lists across the country. And our phones have been ringing off the hook at CMHAs as people have sought out funding sought out service and support and haven't been able to find it. And so we were struck by the fact that our universal healthcare system isn't really universal after all, especially when it comes to mental health. That there's mental health care in Canada, but only some of us will get it. So if you have access to an employer program, you'd be very lucky to get some care. But many of us are not insured through an employer program. Not a lot of service is free. A lot of people are spending out of pocket for psychological services. And that's if you live in a part of the country where you actually have access to services. But as we know, in rural and remote communities, it is very tough to access mental health care. So we decided that we would create a campaign around mental health care with this idea of promoting what would it look like if we had universal mental health care. We know that the Canada Health Act, which determines the funding that goes out to the provinces from the federal government, doesn't cover things like mental health promotion and prevention. It covers psychiatrists and hospitals. So we wanted people to think outside the box about what our mental health care could look like. Next slide, please. So we created a campaign called Act for Mental Health. And it is really an advocacy campaign that rallies Canadians to press our leaders for universal mental health care. We all have the right to mental health care that is publicly funded and free. And yet we know millions of Canadians struggle to get that care. So our research showed that it was the right thing to do, the smart thing to do, and that we can't afford not to. And I really want to address this because it sounds like a big ask. What we're asking for is billions of dollars being added to the healthcare system to address mental health. But we know that when people are underhoused, when people end up in emergency rooms, that the cost to our healthcare system is huge. And so if we can help them through mental health prevention and promotion, then we can prevent them from entering our overcrowded emergency rooms. The idea is to bolster mental health as opposed to waiting until people are in crisis to provide them with that health care. So on my next slide, we've identified the key areas that we believe are essential. And these are recommendations that we are making now to the federal government. First, that there be a mental health and substance use health transfer. So just like there is a health transfer, which was recently announced a couple of weeks ago, we would like to see some ring-fenced money just for mental health. And we've asked that 50% of it be earmarked for community services. And this is essential. As I was mentioning, the services that we provide are not guaranteed at all under the Canada Health Act. So we would like to see community services like CMHA, like the kinds of projects that you're working on, actually have stable long-term funding, and that it be funded in the same way that hospitals are funded, where it's predictable. We've also asked for some legislation that there be a mental health act. And this would actually codify what that money could be spent on and would ensure that it would be a permanent part of our healthcare system. We also want to ensure that the social and economic conditions that contribute to good mental health are met. And so this includes funding for supportive housing, especially for people with mental illness. It includes bolstering disability benefits, basic income pilots, more money for employment programs, especially for people with mental illness, and something simple, automatic tax filings, which would make a world of difference. We also want to see an evidence-based approach to substance use health, basically meaning decriminalization. Next slide. We reached out to partners, and I know that that was an emphasis in this conference that you're attending, this idea of how do we band together in order to do good work. And so we realized we couldn't just go to the federal government on our own, that we had to reach out to others. And so you'll see we have over 35 partners. This is just a snapshot of those partners. We have some of the regular suspects. The Canadian Psychological Association, the Canadian Psychiatrist Association is with us, but we were really delighted to see the College of Family Physicians of Canada and social agencies like Boys and Girls Club, the YMCA and the YWCA step up and say, yes, this is very important to us. So we are using the benefit of coalition to push forward our goals. So this is a long-term plan. We were really hoping to see the mental health transfer in the last budget or in this coming budget. But with the recent health announcement, unfortunately, the transfer wasn't there. But there are some bilateral agreements which will seek to fund mental health through the provinces and territories. And we're now starting to influence the provinces to ensure that some of that funding will go to mental health and that it will go to community mental health. So that's our Act for Mental Health. We urge you to go to actformentalhealth.ca for more information and to sign up to send a letter to the Prime Minister asking for universal mental health care for us all. Thanks very much.
Thanks a million, Margaret. And you still managed to stick to the time, which is amazing. It's so wonderful to just hear about the advocacy work that CMHA are doing in terms of that community mental health approach, and it's really needed. So we really appreciate you sharing that with us. So now, so we're just going to move on to our next presenter now, which is Shelley Cardinal. So Shelley is a member of the Big Stone Cree Nation in Northern Alberta and is now based on the Lekwungen Peoples Territory on Southern Vancouver Island. She is the Senior Director of the Office of Indigenous Relations at the Canadian Red Cross. Shelley has worked closely with Indigenous peoples and communities for over 30 years. I was also fortunate enough to meet Shelley last week, and I just know the stories and perspectives that she will share with you all today will really leave you wanting to hear more from her. So I will turn it over to Shelley now. Thank you.
Thanks, Kate, and Tanse Nihawa all. It's really good to be here, and I want to just thank you for the invitation to be part of an impressive panel. And you know what? I concur with Margaret that advancing mental health and leveraging mental health is critical in today's spaces, and also critical in our learning process. I think one of the things that I have so realized over, especially through the pandemic, is we don't know what we don't know. And I think that through the pandemic, there has been this incredible rise in the general population's understanding that there needs to be a mental health response and mental health resources and accessibility across Canada. I think that there's been really good learning in that, which I've really appreciated. I come from the Canadian Red Cross. I actually have an education and social work background, but have worked with the organization for 27 years now. And I came into the organization really because it was an organization that had a lot of focus on violence prevention. And I was excited to be part of that education and education process around better spreading information around what it is that we need to understand about harm in communities, specifically harm in Indigenous communities, and what it is that we can do differently. It's really interesting in that we had, in the area of education, we have had, an incredible amount of uptake in our education through the years. Like we've probably worked with about 500 Indigenous communities, over several years. But what's been really interesting and concerning is that as a response organization, one of the biggest changes that we have had has been communities connecting with us to better understand psychosocial support, to better understand the link between education and mental health services, and to better understand how it is that as a community, they can start to look at response and response mechanisms within community around the harm and the challenges around either emotional health or mental health that communities are experiencing. For us, we really noticed our rise in our community partnerships and our community response through the pandemic. Last year alone, we actually responded to 734 Indigenous communities, and many of those were looking at various types of social emergencies. So that would have been clusters of youth suicide, that would have been clusters of challenges around either drug or alcohol or community-based violence that was happening. And I think one of the things that's been really unique in our work with communities is that we've started to really look at how it is we can support mental and emotional support within communities, but looking at it through a community process as opposed to the individual processes. As an organization, we're not a counseling organization. We don't pretend to be a counseling organization. We really understand that that is a particular expertise that we are not really, we're not that particular expertise. But what we do understand well is we understand the response within crisis, and we understand that when there is crisis taking place within communities, what are the best things we can do to help create change around that crisis. So one of the things that we had been, and I'll just go to the next slide, Eric. One of the things that we have realized, and we started to realize this some time ago, is that we needed to better work with communities to understand that community mobilization process. How do communities work together and come together to create the change that they are wanting? And as we started to work that through, so we've been doing this very long-term research project, SSHRC-funded research project, together with York University. If we look at the next slide, we can start to see some of the different learnings that communities have started to work with us. It's been really exciting to work with communities around particular challenges, because I think what happens is that so often as educators, as people that have worked in the solution space for a long time, as policy specialists and process specialists, what happens is that we often go and start to work with communities with this understanding that we are bringing the information and the knowledge into community. And so our starting place often gives us this assumption that we're a little ways ahead. And meanwhile, that disrupts at times just the reality that so many of the solutions actually are already within the community. And sometimes we need to our starting place needs to be more at the partnership level as opposed to the support person level. This is one of the things that we learned a lot from community. And so as community started to work with us, it was really interesting. They really differentiated the support and the information already held within the community and the places where we can do work to help community better understand different things. So I'm not going to speak to the first two right away, but what I want to actually first speak to is the increased understanding of root causes of harm within the community and what communities are dealing with. One thing that communities taught us really well is they said, we don't want to actually, work on any kind of questions or information pieces that talk about the harm that we've experienced. There's been enough journal articles and books and gray literature that has really focused on all of those things. So if you could do the work around really looking thematically at what those things are, it would be very helpful to us as community to see what the layers are of challenge within, because sometimes we don't have time or space to look at that. So what we did is we started to actually put several students onto a project to look at that. And if we look at the next slide, then you can see that we did this kind of as an Excel spreadsheet, in that we started to look at like I said, we started to look at books, we started to look at articles, we started to look at various pieces of gray literature, and all in all, we looked at around 1,000 different pieces of literature and started to look thematically at what the challenges are within community. These are just the first three, and it just kind of gives you an idea. But if you look at the next slide, what you can start to see is you can start to see this pattern emerge. And so what we found that there was actually 14 different key themes that really had their own distinct event and space that really spoke to looking at harm within communities. And you can see from this, and there's no assumption that you can read this, no assumption whatsoever. But what you can see from this is you can see a pattern. And you can see thematically at the pattern that as we move forward in time to the right side, and we're starting to look at like 2010, which is just kind of like that second last column, you can start to see how many layers there is. Now, just for a little bit of insight, there's 134 cells that actually have content within them that speaks to harm within community, whether that's legislated harm, whether, so I mean, like just all types of harm, or even different types of normalized pattern harm. But when we start to look at residential school, which is really the type of harm in communities that most of us refer to and most of us have a great deal of information around, that is only 8 of the cells of the 134. It's 8 of the cells. So it gives you an idea around the extent of this, and starting to then build, how do we build not just an education and an awareness process around this, but how do we create a usability process around this? For us, if we look at the next slide, first off, it's kind of like starting to simplify and starting to look at these different layers and helping communities to understand that when there is these pathways of disruption, what happens is that in the absence of intervention and the absence of support, there is going to be a wave of challenges. And so really, we wanted to put it into a type of a picture or a graphic that would actually show, first off, what that looks like when there's several layers together, and also the cascade that actually happens and what happens in the absence then of also addressing the cascade. We also started to look, if we look at the next slide, around how to put it into a process of better understanding. So we looked at things that actually promote the cycle of violence. So again, in the absence of intervention, cyclical process around this. And so all of these things are within the cycle of violence. And what we know is we want to be in the canoe with the communities, and we want to be paddling towards a circle of wellness. We want to be looking at wellness and ensuring that we actually are paddling in that direction. We know that communities want to paddle in that direction, but what does it take to paddle in that direction? If we look at the next slide, we started to really decipher, and this is, for me, I think one of the exciting pieces is that as we started to work more and more with communities, this is the space where we said, what is that reconnection to culture? How is it that we start to look at intergenerational involvement? How is it that we actually start to look at creating a strength-based foundation? Like all of these different themes that came from what we learned from the communities and how they stated the things that they needed. We were able to look at our canoe. We were able to look at our model and start to actually really fill in the canoe. We started to look at, it's kind of like, how is it that we can contribute to the healthy relationships, that we can actually contribute to the emotional safety or the personal power. And it's really interesting. I think that one of the things that we learned so well is that community said, often when it comes to processes or programs that come into community that look at the mental health or that look at the emotional health, we often work with community to come to a place of truly understanding harm, of actually starting to work through that and maybe even doing a bit of a plan for wellness. But what happens is that that often is the stopping point of too many programs or processes. It's often the stopping point. And one thing that communities have said is they said, how is it that we can actually focus on the wellness piece and not necessarily focus on the history, so much, like keep that as a separate type process so that we can actually build agency before we're actually delving more into challenge. And that was really big for us. I think that was really, really big learning, that it's like if we can start to look at supporting the wellness initiatives, especially that are culture focused, especially that are language focused, and especially that are land focused. I think that those were for us three really critical areas: culture, land, and language. That it's like when we can focus on the wellness of those and help to reroute those, there's agency for then the challenges, really to unpack the challenges and have a better place for those. So for us, I think that was something that really was very, very helpful. If we just look at the last slide, for us, what it came to is how do we work with communities to promote cultural connectedness? So for us, it's like we really realize that the more we can support communities around the cultural connectedness and around their culture, the rest of the pieces, from the psychosocial place, we can actually encapsulate into a learning process and keep them in the learning process. For us, I think one thing that we've also really realized is that we, as an organization, like I said, we focus on the whole community, knowing that we're not the counselors, knowing that we're not the individual or the familial support process or space. So we also, I think, are doing much more work with communities to say, let's build your resource network so you know how people can have the individual space, the familial space for their wellness. And what we can do is we can focus on the community patterns to help actually support those in the wellness space so that they actually have a space to thrive. Thank you.
Wonderful. Thank you so much, Shelley, for sharing. And I really loved that visual of the relational determinants. I think it's really impactful to see those visually in one image or two images. But so I just want to give a reminder to the audience members that we will to keep sending in questions. Like I said, you can do that on the Whova platform or within the Zoom chat, because that'll really help with the discussion that we have coming up after Caitlin's presentation. So with that, I would like to introduce Dr. Caitlin Shankardas, who is a social epidemiologist and associate professor in the Department of Health Sciences at Wilfrid Laurier University. And he is also the director of the Health Equity Systems Interventions Lab. So we're concluding this panel session with Caitlin as he brings that broader perspective to mental health promotion, particularly in relation to leveraging intersectoral action to improve health equity, health in all policies, and the recognition for the structural determinants of health. So thank you so much, Caitlin.
Hey, everyone. Thanks so much for having me. Yeah, really interesting presentation so far. And I think I'm going to be able to build on kind of the multitude of drivers of mental health that have been highlighted across both of those presentations. Let me just see okay, great. So this is old data, as you can see, but I'm showing it to you to highlight that while the pandemic has certainly had an outsized impact on mental health problems across the population, the pandemic happened in the context of a much longer term growth in mental health inequality in this country, here seen just between income groups. And so that longer term trajectory likely reflects a similar trend in growing income inequality over the last 30 to 40 years. And so we're not going to stem, if we're not going to stem that trend and make working class people wealthier, then we have to think about how can we use more equity interventions to address differences in well-being. And so this figure just kind of highlights the problem visually. We tend to, with the status quo, think about equality is the fairest way forward for a society where everyone gets the same amount. But we need to invest in specific ways with targeted groups to support their well-being. And that's the idea of equity, that some groups are going to need different types of support. The reality with the status quo and growing income inequality is that there is an ever-growing chasm between the haves and the have-nots, and that's kind of the context in which I wanted to talk about the idea of intersectoral collaboration and the need for it. So we know that the structural and social determinants of health have a profound effect on our well-being. So when we think about, what certain population groups might need to better support their mental health, we can think about a health promotion approach that targets potentially the full range of these determinants. And of course, governments and their various ministries and departments have a big influence on many of these determinants. As well, non-governmental organizations in our communities play a role in many of these as well. So ideally, then, we should be planning in a more holistic way with partners outside of the healthcare sector when we imagine how to improve mental health promotion, I think. And that's the concept behind health in all policies. Health in all policies is not a specific intervention. It's more of a policy idea that different governments have interpreted and implemented in their own ways. I have been doing research case studies. I've been studying cases of health in all policies around the world and at different levels, at the local level, all the way up to kind of the federal level, over the last 10 years. And while there's no single definition of what health in all policies is or how to do it, here are some of the common characteristics that we see with governments that are trying to use a health in all policies approach. There is intersectoral action, meaning different policy sectors, different non-governmental organizations are collaborating in ways that are durable and potentially even systematic. So this isn't just about bringing a group of people together for one issue and trying to tackle that issue together. It's about starting to do your governance in a way that thinks about this kind of more holistic approach to health planning. It involves policy coordination within and across government levels. So, it's not just about everyone kind of understanding the common issue and then going off and trying to do better. It's about working together and collaborating when policies are made, when projects are fostered, so that people are actually trying to tackle these issues collectively, recognizing that many of these mental health issues that we're trying to improve are multifactorial, and there's not going to be a single silver bullet solution. All health and all policies initiatives focus beyond the healthcare sector, and so of course beyond the mental health care sector. Healthcare is incredibly important. When people need support for their well-being, we have to be able to support them. But health in all policies is more of a health promotion approach where we're trying to also avoid the need for healthcare and the unfair distribution of that need. And finally, health in all policies initiatives use evidence. They use evidence to identify which groups are suffering more than others, what the drivers of those morbidity and mortality are, and therefore what some of the solutions that might be useful are. Now, health in all policies to me, when I started doing this research, sounded like a great idea. I thought this is the way we need to have governments reoriented and working. But of course, it's very challenging for governments to transform themselves in this way. For decades, for centuries, forever, governments have worked in what's called a siloed model, where every ministry or department is its own institution. They have a unique budget, they have unique mandates. And when you try to do this kind of integrated governance, all of a sudden people start to share turf. They share budgets, they have overlapping mandates, and there are a whole host of challenges for a massive institution like a government to transform themselves in this way. What I'm going to do now for the last part of my presentation is talk about a specific example of health in all policies and highlight what we've learned about kind of the mechanisms that really help this one case do this kind of work in a more effective way. So in Sherbrooke, in the province of Quebec, They have set up a Ville en Santé for a couple of decades now, actually. And this involves partners from about 50 organizations, governmental and non-governmental, committed to working together to try to make Sherbrooke a healthier place for everyone. Yeah, and so they have framed this as aiming to make Sherbrooke a sustainable, inclusive, and healthy living environment. And notice that there isn't a focus on health exclusively, and that's very important. That's one of the important mechanisms, actually, is that you don't frame everything about health or mental health, that you find more inclusive and broadly, terms that all of your partners are going to buy into and say, yes, part of our mission is to do that. And so in Sherbrooke, they found that sustainability, inclusivity, and health are kind of those issues. They do, what do they actually do? They respond to needs and challenges that they're identifying using evidence by developing collaborations and working to make them autonomous once they develop them. And then they are also trying to facilitate the good collaborative work that's already happening in the community. I'm going to focus in on one example of what they've been doing lately related to mental health. So they learned using evidence that they had a big issue with youth drinking, youth alcohol use. Some of the data here, they noticed that many youth in Sherbrooke are drinking before the legal age, at least trying it. And that over a recent 5-year period, there was an enormous number of alcohol-related hospitalizations for youth, including very prevalent consumption of high alcohol content drinks. Many of the hospitalizations, at least half of them, had complications, medical complications. The criminal justice system was involved in about 10% of them. And they also noticed that alcohol, relatively cheap alcohol, was available to people who wanted to buy it. Far below the recommended kind of pricing point if you want to kind of keep consumption at a reasonable level. So they formed a working group within their Ville en Santé to focus on how can we improve our municipal alcohol policy. And what they decided to work on collaboratively was better information and education, having more community safe spaces when they knew there were going to be events where there was going to be a lot of drinking and potentially a lot of, say, university students drinking. And then they worked with industry to try to have more availability of lower alcohol content drinks. And they worked with local microbreweries to do that. And there you can kind of see how this collaboration you can kind of imagine it taking root and people saying, well, we don't want to just kind of give more business to the big companies. Let's kind of invest in the community, because I'm sure there was some people from the Chamber of Commerce who kind of put that on. What I'm going to spend the last few minutes of my content here on is our research, where we interviewed about 15 people from this working group on the municipal alcohol policy to find out how did they do this kind of collaborative work in a way that was satisfying, that was sustainable, that was really effective. And there was kind of 4 takeaways here. And I'm just going to give you a fraction of the recommendations from these 4 themes, but just to give you a flavor for the types of mechanisms that are needed here. So the first one is they had to do something to foster alignment across all of these different partners that they're expecting to collaborate. And so the one which we've already seen a little bit about it was using compelling facts. They started off their collaboration with a bit of a fact-finding mission, and they surfaced to define the nature of the problem. And people around the table really felt compelled that this is an issue affecting our whole community, and we have a responsibility to help tackle this. And so you can see through the quote there, I won't read it, but the use of data really helped them start to get into motion about planning together. What can we do as a part of our institution, as a part of our organization, to contribute to this big problem that you're showing us? The next kind of theme about how do you do this type of collaboration effectively was trust building. So different organizations, different departments in a government are going to, of course, when you start to try to integrate them, have some concerns about territory. These are the things that we typically control in the community, and now we're bringing other people into this. But it's also ideas, ideologies. Different organizations have different ways of seeing the world and understanding the role of society, for example, and their role. And so trust building was really important early on in particular. And the way that the Ville en Santé did this is they kind of made sure that the first groups that they brought together either had some pre-existing relationships, so there was already a bit of trust built into there, or they had some kind of common values or ways of seeing the world, so that they could start the core with a very strong foundation of trust and understanding about the problem. And then they could kind of build out more members from there. The third kind of theme here is how do you actually then induce engagement and sustain it over time? So how do you get people to then start to actually plan together? And this is a recommendation that I've seen virtually in every case of health and all policies I've studied over the last 10 years. It is that win-win approaches work. And this is where you're finding opportunities to develop projects that give more than one organization a win. You can't really expect everyone to come together to help one organization do their work better. You need to find opportunities and projects that are going to give multiple organizations and partners a self-interest in continuing to do this work. And so in Sherbrooke, we heard from people, from many of our informants. And here's just a quick quote. I think it's because it serves the mission of those who are already in place. It doesn't take away anything from them. What you're doing is kind of building on everyone's good work. You're not trying to sort of redistribute that effort. And finally, leadership. And this is probably should have been number one. There is no health and all policies initiative that has happened without strong leadership. You simply have to have somebody who is powerful and recognized in their leadership, who is saying locally, this is something that we all need to do. And if you don't have that person, if you don't have that strong leader, it's going to be really hard to convince a wide range of partners to start to devote some of their resources to this. So people need to know that this is important. Leadership is important in so many ways, and these are just a few of the strategy or the ways that leaders were helpful in Sherbrooke. They were passionate about these issues. They were the ones who were kind of showing that evidence and saying, look at this, isn't this terrible? Isn't this something that we can't continue on with? And they were always there with that energy, motivating people to continue to care about this issue. They were helpful by making sure that meetings and general work was results oriented. So all of those partner organizations really appreciated being a part of something that was actually productive, that was not just continuing to define the problem, better understand it, strategize, but that they were actually doing things and accomplishing things. So you need to have leaders who are results oriented. And finally, strong leaders in Sherbrooke were strong. They were recognized for being strong because they listened to their members. They spent time in meetings and outside of meetings, really trying to get a handle on all of the partner organizations' mandates. If they were outside of government, for example, what are the unique expertise that everyone's bringing to the table, so that everyone felt valued and everyone felt like their contributions were essential to the collective. It wasn't just some sort of faceless kind of collaboration. It was really a sum of its parts and beyond that, and it was recognized that way by the leader. So these are just a few of the mechanisms that we learned about in Sherbrooke. There are many more mechanisms, and we actually did a series of 5 case studies across Ontario and Quebec at the local level recently, using a CIHR award. And I just want to recognize some of the other scientists and researchers on that team. And so, if you're looking for mechanisms about how to do these types of collaboration, there are going to be some that are kind of universal across, wherever you're doing this kind of work, like looking for win-wins. And then there are going to be some that are going to be local to your jurisdiction and to the collection of people that you're working with. And so, I think I kind of want to end by just kind of giving people inspiration that this type of collaborative work is necessary, and it's going to be really challenging. But there are a lot of great examples about how you can kind of try to work your way through it in a successful way.
Thanks a million, Cathan. That was fantastic. And I really liked the example from Sherbrooke. I think it's always nice to have a story or illustration to show how those key mechanisms are working. So really appreciated that. So I just want to thank all the presenters, and we have had a few questions coming in, but just to kind of wrap up on I'll just say a few words first. So I just really enjoyed listening to all three presentations, and that they really are focusing on that mental health promotion perspective of taking that upstream approach and really looking beyond just the individual or behavior changes to really look at more of those social, relational, and structural determinants of health. I also really enjoyed, I'm not sure if all attendees are aware of the WHO's action areas from the Ottawa Charter, which was the first international conference of health promotion, really identified kind of 5 key levers or action areas for health promotion. And throughout these presentations, I actually saw these levers or action areas present. So within Margaret's presentation, we heard about the importance of reorienting the health services and building momentum, about increased community mental health services. Shelley talked about the action area of strengthening community action and empowering Indigenous communities and using that as a mechanism for mental health promotion. And finally, Cathan touching on the action area of building healthy public policy and highlighting that as a critical mechanism in transforming mental health and well-being and health equity. So really great to see health promotion really at the forefront of all of those presentations. So just to kick it off, I'm going to just start with one question that I have for the presenters. And I think I also saw this idea of partnerships and the importance of partnerships and collaboration woven into all of the presentations. So my question for you is, how do we leverage, inspire, or encourage partners in other sectors, communities, and disciplines to prioritize mental health promotion and that upstream approach? So, Margaret, would you be happy to share?
Sure. You know, I was really interested in Cathan's presentation that talked about the fact that we don't just talk about mental health necessarily or health outcomes, but that we make it much more broad. And I think that we can get siloed within mental health. And so appealing to partners at a broader level is more about well-being, other kinds of language that engages the whole person. And I love the medicine wheel model in what Shelley was presenting. It's the whole person we're talking about. And I think that is one way to appeal to partners, that we're not just talking about the 20% of people who may have a mental illness, we're talking about the 5 out of 5 of us who all have mental health.
Absolutely. Thank you, Margaret.
I could add on to that. You know, I think like I was just listening to the CBC earlier today, and I don't know if anyone heard about the 4-day work week and the evidence about how, you know, many companies in this UK study that tried it, they're going ahead with it, over 90% of them, because it was so successful. And that's the idea here, is that if you expect the local chamber of commerce or your Ministry of Employment or your Ministry of Industry to get on board with trying to change working conditions to promote mental health better, you need to have a focus on this broader concept and concepts that are going to appeal to them. And if the Chamber of Commerce cares about productivity and how better mental health will lead to a more productive workforce, even though that might not be your interest and you might think that's a really narrow way of viewing the world, realistically, if you want to have them as a partner, you need to find a way to frame and at least communicate why improving mental health will improve productivity. So in Elgin St. Thomas in Ontario, they're also doing this kind of a collaborative policymaking approach. And they have decided that their mission is improving quality of life, right? Which is such a broad concept, but it also includes everything there. Quality of life, and so you can see how that could be really attractive to having different organizations see themselves in the mission ahead.
Thanks, Cathan.
You know, I think that, you know, it's really interesting. I think about intersectionality, and intersectionality is a real growing space within our understanding. And within community, I think that how we view that is we view that as holism. And it's kind of like, how do we look at the whole self? How do we actually understand that when we focus on wellness in any part of a person, if we bring in the right questions into that space, we can actually help expand that regardless of what we're focusing on. So I think to myself, like within community, and I think, within the school system, within society, there's this big concentration on the physical. The physical is often the space within sports that we focus on. The physical is often the space that health has often focused on. And so if we start to look at, starting to bump out those other aspects of the person and say, what does wellness look like? If you were to focus on this, how does that make you feel? How is it that improves or just contributes to maybe a better sleep? Or how does that contribute to maybe a different relationship with your parents? Or how does that contribute, So all of a sudden, if we're to focus on maybe the right questions that just go to a holistic space and take people to that holistic space, that in and of itself helps to integrate mental health and mental wellness. I also believe that we're at a critical time in that there's so much more awareness around mental and emotional health. So to me, it's the time to push it. Like when there's an uptake and an understanding of what we need to focus on and how important it is to focus on that, go for it. Like everybody should be going for it to the greatest extent that they can. Apply for as much money as you can. Apply, like to me, it's kind of like push it, because really there's still such a long way to go. There's such a long, just such a long way to go. Communities and intersectionality understand all my relations. They understand looking at things from a holistic space. I think what happens is that often our funding mechanisms and our policy processes tend to disconnect things and make them stay disconnected and say, no, that's not our objective. That's not our objective. No, we if you're working on this, then we can't fund that. And so to me, our space and our concentration needs to be in that intersectionality. It needs to be in that intersectoral space to help push the policy drivers, to help push the education pieces, to say, we need to open this up. Community and working with Indigenous community, we know that space already. It is, and we're coming back to that space. And there seems to be more and more partners that are understanding how to come back to that space, so yeah, so that would be my thinking there.
Wonderful. Yes, I agree with what everyone's saying there in terms of I think that intersectoral approach is very important, and but looking at what the priorities of the different sectors are, like Cathan was saying, and really what are their agendas, and making sure that mental health is part of their agenda, no matter what sector they're in. So, and like Margaret was saying about the language and ensuring that kind of positive language to mental health, and that just like physical health, everybody has mental health. So it's not just the 20%, as you were saying, it's looking beyond it, the health for everyone. Wonderful. So we had another question come in, and I think a lot of the people that are joining today are working with projects with young people, children, young people, or families of young people. And there was a question here of, what do you think is the role of youth voice in shaping or reimagining universal mental health? Anybody?
Shall I jump in? Yeah.
Yeah, of course.
We have been on a mission of late to really think more deeply about how we incorporate the voice of lived experience into our work. And we've had a notion of patients being at the center of our work. And now we're trying to think more about patients or people with lived experience driving the work that we do. And I think in particular, I'm so impressed by young people these days in their ability and willingness to talk about their mental health. They're much more open, much less constricted by stigma, and willing to share openly. I'm afraid it may be because they're dealing with much worse circumstances. than older people, certainly. You know, it's tough to be this generation that's graduating from school right now, for example, or new to the workplace. So I think it's really important that we hear from young people, because I think they have a fresh perspective, but also I feel that the struggles that they've had over the last 3 years of the pandemic in particular have taken a terrible toll on their mental health. So it's critical that we be driven in our approaches by that voice.
Thanks, Mark.
We've been working with many communities to set up committees within community, and often, you know, and wellness-based communities. So it's kind of like, what are the different areas of wellness that the community is really working on and working towards? You know, what we know is that if a community has invited us in, it's because there's some aspect of crisis in the community, and they're wanting to change that crisis. They're wanting to move to a different place. And so often when we're setting up committees within community, we're really we try and use particular formulas, you know, and part of the formula is, can there be two youth? So not necessarily a youth voice within the committee, but two youth voices, because what happens is that when one, if we actually put the burden to one youth, there isn't somebody for them to have a conversation with, often within that space. And so usually when we look at youth inclusion, sometimes our challenge is that we leave space for a youth voice at the table, and there needs to be a different thinking than that. You know, for us, we also say, can we have at least two elders within the community? So it's interesting, because as communities were saying to us, that intergenerationally, we need to ensure that all of the generations are included. We're a real adult-centric society, a real adult-centric. And what happens is that we're also a real sector-centric society. So it's kind of like, have somebody from justice, somebody from health, somebody from education, you know. So the thing is that this is often how we think about inclusion. And meanwhile, we don't often think about inclusion across generations as opposed to across sectors. And so we've tried to work with communities a little bit differently to say, let's look across generation, you know. And it's okay. Like, it's okay if you don't have somebody from all of the sectors. If you have somebody from all the different generations, there's actually going to be an easier ability to look at culture as being the driver for change, as opposed to the particular sector being the driver for change. And so trying to kind of move it outside and away from that.
Absolutely. Thank you so much, Shelley. And we were just really short on time. So if Keithan has anything final to add?
Just really briefly, I mean, we know when we, as an equity researcher, that if you're trying to help an equity seeking group, you must include them in defining the problem. I'm just building on some of the comments in the chat as well. You should be including them if you're concerned about improving youth mental health in defining what is the problem, all the way through to what would be the solutions that would be helpful. And I don't think I need to say anything more.
Absolutely. Yeah, not that tokenistic approach, as you said, throughout the whole process is key. So I just want to take the opportunity to thank all of our panelists today. It was really great to hear through all the presentations. And the only unfortunate thing is that we didn't have more time, because I'm sure we could listen to all of you speak for a lot longer. So thank you so much. And I'm going to turn it over to our co-directors.
Thanks, Dr. Dowling. Thanks so much for moderating the panel, and thank you to our panelists. I echo Katie's comments, and you've just really described specific evidence of momentum that can improve mental health of populations, and tipping points, leverages, ways to look at the holistic health of Canadians. So as Shelley mentioned, let's all climb into the canoe and paddle into the direction of the circle of wellness together. So thank you for that. So next we'll move to our fourth and final session of the day, concurrent sessions moving mental health promotion forward. And just a brief instruction, so you can select one of 8 rooms that align with your professional or passionate interests and join others with shared interest in mental health to participate in a 3-part group discussion, and it's focused on a variety of levers of change. So we'll continue that conversation. And just before the next session, it's time for us to take a wellness break, have a stretch, and please return to our concurrent session, so session 1D at 1/2 the hour. So that will be in just over 10 minutes. Okay, so thanks for joining us, and we'll see you shortly.